Okay, so we will start our session with the pre-test. I would request IT team to show the pre-test. Uh, so you will, I mean, getting the questions. Okay, so pre-test is here. So I will request all the participants to attempt this pre-test, and we will show results in the end after doing post-test of same questions. Okay. So I'm reading question for you. A 32-year-old female presents with secondary amenorrhea, galacturia, and decreased libido. Laboratory results show serum prolactin level of 250 nanogram per ml. MRI of pituitary reveals a 1.2 centimeter lesion confined to the cella. What is the next best step in management? Okay, so I think 14 participants have attempted. Okay. So I would request you to do it fast. I mean, time is over, but I can see that people are attempting this pretest. I think now we should move to the second question. Okay, so this is the second question. 45-year-old male complains of progressive loss of libido and erectile dysfunction for 6 months. On examination, he has bilateral temporal visual field defects. Serum prolactin levels are 2500 nanogram per ml, and MRI reveals a 2.5 centimeter pituitary mass with compression of optic chiasm. What is the most appropriate initial treatment? I would request all the participants to please, do it in a hurry because so that we can proceed with the session. So I can see 77% participants have done this question. I think now we can move to the third one. Okay. So 28-year-old pregnant woman with a history of microprolactinoma presents at 16 weeks of gestation. She had been on cabergoline prior to pregnancy, which has discontinued once her pregnancy was confirmed. She now complains of worsening headache and visual disturbances. Visual perimetry shows right superior quadrinotopia. MRI shows an increase in the size of pituitary lesion to 14 millimeter with suprasellar extension. What is the most appropriate course of action? I would request all the participants to do this pre-test because this is going to help you learn better. So now we can move to the next question. Okay, so Okay, next question is 52-year-old male with macroprolactinoma, 1.5 centimeter, has been on cabergoline therapy for 12 months. His prolactin levels have normalized and the tumor has significantly reduced in size on follow-up MRI. What is the next step in his management? Select any one of them. Continue cabergoline therapy and monitor prolactin levels periodically. Discontinue cabergoline and repeat MRI in 6 months. Proceed with transsphenoidal surgery for residual tumor. I can see 68% have participated, 68% of the audience. Um, and now we can move to the next one. Okay, so this is question 5. 35-year-old female with a history of macroprolactinoma, 6 millimeter, presents for follow-up. She has been on cabergoline for 2 years and her prolactin levels have normalized. What is the most appropriate next step? Continue cabergoline indefinitely, gradually taper and discontinue cabergoline, repeat pituitary MRI. Okay, so I think 73% have participated. So let's move to the next. Okay, so next, I think this is the last one, right? All done. Okay. Okay, so we are going to share results in the end, okay, after doing the post test of the same question. So let's move to our session. I would request Dr. Aisha Sheikh to take the lead. And Dr. Aisha is going to discuss clinical practice guidelines. And if you have any questions, we can share in the chat box so that we can take those questions in the end of the session. Okay, over to you, Dr. Aisha.
Bismillahirrahmanirrahim. Assalatu wassalamu ala khatamin nabiyyin. Iram, is the screen visible? And am I audible?
Yes, you are audible and screen is visible.
Okay, so thank you very much. So, as most of you who were there in the Pakistan Endocrine Society's annual meeting in the month of October at Lahore, you would have witnessed the launch of the Pituitary Adenoma guidelines. This is a resource adapted approach for lower middle income countries. And this is a joint effort of Pakistan Endocrine Society and Pakistan Society of Neuro-Oncology. And as we already decided that we will keep a dissemination phase of the guideline as well. So we are lucky to have the first session today. I'm really honored to have the kind presence of Professor Najmul Islam, who is the mentor for this guidelines and has overlooked and overseen actually all the process. And Professor Emerita Dr. Tasneem Hassan, and both of them have a vast experience in managing pituitary adenomas in Pakistan. So let's go till, I have kept certain cases so that we can relate this to clinical practice and improve our understanding for managing prolactinomas and hyperprolactinemia. So this is a 34-year-old woman who has This is a 34-year-old woman who has had fatigue, weight gain, irregular menstrual cycles, and milky discharge from both breasts for 6 months. Physical examination revealed a small goiter, dry skin, and bilateral expressible galactoria. You did a pregnancy test which was negative, and a prolactin level was tested twice, which was 55. And thus, a pituitary MRI was done. And you can see, I'll just put it on. You can see that there was a large pituitary or a mass over there. So the question is, and you can use the chat box to answer this question, what is the most appropriate next step in the management of this patient's hyperprolactinemia? Will you start an oral contraceptive pill for her, start dopamine agonist therapy, check her TSH level, or refer for transsphenoidal surgery? So can you use the chat box to write your options, which you think is the correct for this? We'll just wait for a couple of seconds. And let's see what most of you think. Okay, so we can see that they are, you can just write the option, the A, B, C, or D rather than, yeah. Okay, so the house is divided, and this shows that we need to understand these things. If you go back to this patient's history, you will see that there were certain clues in here. And I'll just, and those of you who said you will like to check her TSH level should congratulate themselves, because this is the patient who has primary hypothyroidism. And remember, primary hypothyroidism can lead to thyrotrope hyperplasia that can mimic a pituitary mass. And the prolactin can be elevated by mechanisms that we'll just show. So as you all know, that prolactin is a polypeptide hormone, which is a 198 amino acid molecular weight of 22,000 daltons. And dopamine, which is the prolactin inhibitory factor, has a tonic inhibition on prolactin production. However, during pregnancy and in lactation, the suckling reflex will actually lead to increase in prolactin through a feedback mechanism. And then we know that TRH, which is secreted, that thyrotropin releasing hormone, which is secreted by the hypothalamus, will actually have a stimulatory effect on both TSH production from the pituitary as well as the prolactin. Okay, so coming to our case 2. This is a 41-year-old married lady with 4 children. The youngest is 4-year-old. She complains of irregular menses for 2 years and amenorrhea for last 4 months. She has headache, but no visual problems. The lab investigation reveals estradiol, which is 10. You can see FSH, which are low or inappropriately normal for this estradiol, suggesting that this is hypogonadotropic hypogonadism. Her TSH and FT4 are normal, so there isn't any hypothyroidism over here. Her cortisol, morning cortisol is normal, which means that her hypothalamic pituitary adrenal axis is normal. And then you check her prolactin level, which is 65.62. And this is the pituitary MRI. I'll just increase the size. You can see that this is a macroadenoma. Clearly, this is a macroadenoma over here. And then you wonder, how can this macroadenoma be associated with with a prolactin level, which is 65? So we all know, and those of you who haven't actually been familiar with this thing, that prolactinomas secrete prolactin proportionate to their volume. So the tumor size is proportional to the prolactin level. And if you come across such tumors with this kind of modest elevation of prolactin level, you just wonder whether this is prolactinoma am I dealing with, or is there something else? So remember, any tumor, so prolactin would be released from the tumor itself, the lactotroph adenoma. But a tumor which is actually inhibiting this dopamine flow, the prolactin inhibitory factor that we earlier mentioned in the previous slides, will lead to loss of this dopamine inhibition and can lead to modest elevations in prolactin. So the tumor might be a non-functioning adenoma or another supracellular mass that is leading to stalk effect. This is called as stalk effect. This is inhibiting the flow of dopamine from the hypothalamus to the pituitary, thus removing that inhibition of dopamine on the electrotrophs, leading to prolactin release and increase in the prolactin level. The other situation could be, and this is very interesting, the other situation is a biochemical artifact. You can say artifact or biochemical concern that we, unless we are familiar with this, we can easily miss it. So remember, whenever there's a high amount of circulating prolactin, this causes antibody saturation. So these are two-side assays that we are using in chemiluminescence methodology of hormonal assay estimations. And when the prolactin levels are very high, that will result in saturation of the antibodies and leading to artifactually low levels of prolactin. So actually the prolactin level is very high, but the assay is artifactually capturing it as modestly elevated or maybe near normal prolactin level, although the tumor is a prolactinoma. And can we differentiate between these two scenarios, whether this is a stalk effect or a hook effect, because the management of both would differ. So you can see that you can do dilution of prolactin, serum 1:100 dilution. And if even after dilution, the levels do not go further up, that means that this is a stalk effect from compression of the stalk. And if there is increment, so you can see that actually the tumor was a prolactinoma, and it led to, after dilution, you can find 13,000 nanogram per ml of prolactin level. That actually now you can correlate it with that kind of tumor size that we saw in the last slide. So whenever you come across tumors which are macroadenomas in pituitary, especially giant macroadenomas like tumors which are more than 3 centimeter, maybe tumors which are 1.5 to 2 centimeter or higher size, make it a habit to test the prolactin on 1:100 dilution. You have to inform the laboratory to get a prolactin estimation on 1:100 dilution of the serum sample, so that you can differentiate between these two scenarios, and that will be valuable in terms of managing this patient. So coming to case 3. This is a 27-year-old lady married for last 6 months. She is unable to conceive, referred by her gynecologist for raised prolactin levels. She has regular menstrual cycles. On examination, her BMI is 21. No hirsutism or alopecia, no expressive galactoria. Visual fields are full to confrontation. Prolactin level was 83, TSH is 2.1, FSH is 6, and LH is 3. So you can see that the levels are elevated, and you think whether, but this patient is having fertility problems, but is having regular menstrual cycle. Should I take prolactin level of 83 as it is, or should I be concerned whether this is something else? The other thing is important that remember, prolactin is one hormone that is influenced by a lot of factors. Even the stress of a needle prick can falsely increase prolactin level, which means that testing prolactin during the menstrual cycle and menstruation phase, like day 2 or 3, is not a very good idea, especially if the woman is having dysmenorrhea and is not in her basal state of health. It's not a good idea to check prolactin. So again, make it a habit to check prolactin in basal states when she's comfortable, she's stress-free, not having pain, because these can artifactually increase the prolactin level. So this is one thing that we need to keep in mind. Prolactin molecule in our circulation could be the monomeric prolactin, which is the small size prolactin, and this is the prolactin which is biochemically active. The other big prolactin or big prolactin, big prolactin or microprolactin over here, you can see that these, if present in a patient's sample or serum, will actually be recognized by the assay as high prolactin level. But if you do a PEG precipitation of that assay, you will find that the high prolactin level was because of these inactive, which are biologically inactive molecules, rather than the active monomeric prolactin. And so you can see that few laboratories are given the monomeric level in routine and make it a habit to question whether this is actual prolactin elevation or a macroprolactin or big prolactin that is artifactually leading to high prolactin level. So you looked at the monomeric level, and this was 13. This was well within the normal range for the monomeric prolactin. So you can easily tell that patient that no, this is not hyperprolactinemia. It is normal, and you do not need further workup or management with regards to the prolactin level. Okay, so our recommendation 1.1 for our guideline chapter on prolactinoma suggests the clinician should consider certain pitfalls in the diagnosis of hyperprolactinemia. The clinician should take a detailed history and relevant workup. So this is very important. Do not shy away from taking detailed history examination of your patient's relevant workup. So case one where many of you missed testing a TSH level to rule out other possible causes of hyperprolactinemia. And then confirm hyperprolactinemia. So if there are equivocal levels, borderline cases, prolactin levels in 30s, 40s, 50s, 60s, test prolactin level again with all prerequisites like a fasting sample. Make sure she's not on, he or he is not on any medications that could vastly elevate the prolactin level. So coming to our next case, this is case 4, 47-year-old lady, history of schizophrenia, referred by gynecologist for high prolactin level. She has complained of hyperpigmentation over cheek and scalp hair loss. Her last menstrual period was 8 months ago, and these are her medications: fluoxetine, procyclidine, and fluphenazine. No expressive galactoria, no field defects on confrontation. Lab test shows a TSH, normal TSH. Her gonadotropins are well within the levels of menopausal state. Her estradiol, again, this is all showing menopause. Her prolactin estimation was done twice, which was 210 and 132. So what to do next? And you come across such patients time and again. So remember, hyperprolactinemia could be because of a variety of physiological and other causes. It's not like a hyperprolactinemia will always be equal to a prolactin secreting pituitary adenoma. So there are physiological causes, and always rule out pregnancy in women who are sexually active. Lactation, there isn't a point testing prolactin level during lactation. Exercise, intercourse, nipple stimulation, stress, seizures, all will lead to increment in prolactin level. Similarly, we discussed macroprolactinemia, where you will be looking at the monomeric prolactin. Hypothalamic and pituitary lesions. So one is prolactinoma itself, but again, stalk effect due to non-functioning masses leading to stalk compression. Adenomas, any adenoma, craniopharyngiomas, Rathke's cleft cyst, meningiomas can lead to this. Similarly, if there are inflammatory, infiltrative lesions, hypophysitis, lymphocytic hypophysitis, Langer's cell histiocytosis, empty cellular syndrome, and pituitary stalk section. Other illnesses like hypothyroidism, we saw this in the first case. Chronic renal failure can lead to high prolactin because of the reduced prolactin clearance, which actually normalizes after renal transplantation as well. Neurogenic causes, so if there are any chest wall lesions, spinal cord lesions, breast stimulation, all can lead to increase in prolactin levels. And there is a long list of drugs, and this list might not be complete. Remember, whenever you come across a patient and the patient is on certain drugs, make it a habit to look for whether this drug is causing hyperprolactinemia. And remember, drugs lead to hyperprolactinemia because of the dopamine antagonistic effect. And these are very notorious: metoclopramide, risperidone, levosulpiride, amisulpiride. These can increase prolactin immensely. Compared to other drugs, which may be up to 200 milligram per DL, but risperidone and metoclopramide can lead to increments more than 200 nanogram per ml. Similarly, estrogens in high doses can lead to prolactin elevation, verapamil, certain opioids. Then ectopic secretion of prolactin can be found in, which is very rare, renal cell carcinoma, perivascular epithelioid cell tumors, gonadoblastomas, and ovarian teratomas. So our next recommendation is that assess prolactin levels after drug withdrawal in symptomatic drug-induced hyperprolactinemia. So if the patient is having any symptoms like amenorrhea or galactoria, you can consider stopping the drug for a week or so and then reassessing prolactin level. But the situation would differ in a situation where the patient is having schizophrenia. You cannot make the decision of drug withdrawal after consultation with the patient's treating psychiatrist, and only with a mutual consent you can consider withdrawing the drug or switching to another appropriate drug that might not be leading to hyperprolactinemia by its mechanism of action. The other is that in olden days, few people mentioned dynamic test. Dynamic test which are done in to stimulate a secretion, hormone secretion or suppress a secretion. Those tests are not required in the assessment of hyperprolactinemia. So do not think about doing dynamic test in assessment of high prolactin level. So coming to our next case, this is a 24-year-old lady married for 2 years. They took oral contraceptives for 1 year after marriage, and then after continuing her oral contraceptives, she developed amenorrhea of 1 year duration. Galactoria for 6 months. No headache or visual field defects. Her beta HCG is negative. So remember, as we mentioned, in women who are sexually active, make it a habit to rule out pregnancy in such situations. TSH is normal, prolactin is 90, and you get her pituitary MRI, and you can see that this is a nicely located pituitary microadenoma, microprolactinoma. This is the optic chiasm, so it's well away from the optic chiasm. Okay. So prolactinomas actually are the most common among the most common pituitary tumors, which need management. So considered to be almost half of the tumors, pituitary tumors that need some kind of treatment. And if you learn about prolactinomas, you will actually be able to learn almost 45% of the pituitary adenomas. The clinical features, you all are already familiar with women galactoria, in men gynecomastia. Galactoria is very rare in men because you need estrogen primed breast for galactoria. This is a very remote side effect that a man can encounter. In women, again, oligoamenorrhea and infertility, that is the reason they report very early, because they get menstrual cycle irregularities and they report to their healthcare professionals and are early diagnosed. In men, they have more of hypogonadal symptoms like erectile dysfunction, reduced libido, and infertility, and they tend to ignore the symptoms, and so they present late and mostly have macroadenomas. And then there are other other clinical features like headaches because of the tumor itself, because of hypogonadism, osteopenia or osteoporosis can occur. Mass effects, if there is a macroadenoma, so visual loss, cranial neuropathies, hypopituitarism, temporal lobe seizures, and CSF rhinorrhea all can occur with these tumors. The degree of hyperprolactinemia varies. If there's mild, and this is mild true hyperprolactinemia, if it's between 20 to 50, it could just only present with subfertility. So a short luteal phase, the patient even not be having any menstrual cycle irregularity, just a subfertility. Moderate, 50 to 100, where there would be amenorrhea or oligomenorrhea, and severe, where it is more than 100, which will present with overt hypogonadism, amenorrhea, hot flashes, vaginal dryness, and long-standing would lead to bone loss as well. So when we look at the patient with certain clinical features, we check prolactin level if these are normal or elevated. So if they are normal and you have a high index of suspicion, because this was the case that the prolactin levels were modestly elevated, you will like to recheck prolactin in a fasting state with all prerequisites. So remove any offending drugs, make sure the patient is not having intercourse in preceding day. Again, if there is a history of renal disease, no further testing is required until and unless they have significant symptoms like visual deficit, headache, or hormonal imbalance. Similarly, assess the medication history. If he or she is on these drugs, which we know that can lead to drug-induced hyperprolactinemia and very high prolactin levels, you can consider testing pituitary MRI if the prolactin level is more than 300. If you can easily switch the drug to something which does not affect prolactin level, reassess in a week's time. If that is not possible to safely stop the medication, then depending upon the medication, further course is taken, which is if she is on antipsychotics, which we know that can lead to very high prolactin levels, you get the pituitary MRI. If she is on other medications and if the levels are more than 100, you can consider pituitary MRI. If that is not the case, consider other testing as well, and look at the whether there is persistent elevation of prolactin and needs pituitary MRI. Decision of pituitary MRI should be on physician's discretion if there is moderate to mild to moderate renal impairment, if there is high prolactin with symptoms, and depending on the renal impairment severity, one can consider pituitary MRI in such situations as well. So again, history is important. Physical examination would include looking for galactoria and visual fields, and similarly lab tests rule out pregnancy, check for hypothyroidism, look for any renal failure, check prolactin, recheck prolactin in fasting if there are equivocal results. And if there is a macro prolactinoma, always keep in mind to check the anterior pituitary function. Get a pituitary MRI, and definitely this will come when you have the pituitary MRI in hand. And visual fields if the MRI shows any optic chiasmal compression. So the next recommendation is to obtain a pituitary MRI with and without contrast after other reasons for hyperprolactinemia have been excluded. And then assess anterior pituitary hormonal function in patients with macroprolactinoma on pituitary MRI. And in patients with macroprolactinoma on pituitary MRI, where the tumor is abetting or impinging the optic chiasm, visual field assessment with formal perimetry should be obtained. And then again, several causes of hyperprolactinemia lead to prolactin elevation in different ranges. You can see that drugs generally would lead to elevation 100 or something. If there are very high such kind of levels, we know that this is macroprolactinoma and you can straight away go for pituitary MRI. Similarly, in other situations, there would be different ranges of prolactin levels. And this is how, if there is chiasmal compression, the bitemporal heminopia would look like. So how to manage? So our recommendation 2.4 is to initiate dopamine agonist at the lowest dose and gradually up titrate the dose to achieve normalization or near normalization of prolactin level. Offer hormone replacement therapy in women with microprolactinoma. So suppose there is somebody who is not having troubles in galactoria and is not desiring fertility, is having a microprolactinoma, you can just offer HRT as well to counter the hypogonadal symptoms. And similarly, in men, this can be offered if they are intolerant or resistant to dopamine agonist, have a microprolactinoma, and do not desire fertility. And one can even offer HCG treatment to those who desire fertility. So this would be 2.5 and 2.6 recommendation is for unique situations, would not be applicable to every patient of microprolactinoma. So indications of treating prolactinoma is when a macroprolactinoma is causing visual field defects or an imminent risk to the visual field, neurological symptoms, and hypogonadism. Symptomatic patients with hyperprolactinemia who are presenting with galactoria or hypogonadism, and women with regular menstrual cycles and mild hyperprolactinemia who are attempting to conceive, as we earlier mentioned that there could be luteal phase defects, but you have to be sure that this is true hyperprolactinemia. Most of these are medically treated with dopamine receptor agonist, and these are the initial treatment to patients with macroprolactinoma, even with visual field defects. Both cabergoline and bromocriptine are available in Pakistan. Both are agate derived. Being endocrinologists, most of us would favor cabergoline over bromocriptine because of the fact that the side effect profile is better. The frequency of dosing is also very practical. So just twice per week dosing. Generally, you start with something like 0.25 mg twice weekly and then continue to build up according to the response or depending upon the initial levels as well. Treatment efficacy is more robust with cabergoline compared to bromocriptine. Side effects like nausea, headaches are more frequent with bromocriptine. But remember, cabergoline, if taken on very high doses of a longer duration of time, can lead to cardiac valvulopathy, and we will discuss this in subsequent slides as well. Impulse control behaviors have been reported with both agents. So we should be on the lookout to for patients or the caregivers to report any impulse control disorders. CSF rhinorrhea is reported with these both two, and tumor fibrosis is reported with bromocriptine. The typical starting dose of cabergoline is 0.25 to 1 milligram twice per week. Using such doses, the studies have shown that prolactin levels normalize in 61% of patients and gets reduced by at least 75% of the patients. So very good response with dopamine agonist therapy. The goal of this therapy is actually to normalize prolactin level and relieve associated symptoms, reduce or stabilize tumor size, preserve or restore pituitary function, and prevent disease recurrence or progression. And this is again use of dopamine agonists over a longer duration of time, and it's been reported that during the first 6 months of management, actually the maximum response is seen in these patients, and later on, although the response rate continues, but the maximum biochemical and even radiological response is observed during the first 6 months of treatment. So our recommendation 2.1 is to offer medical treatment with dopamine agonists to patients with prolactinoma to normalize prolactin level, reduce tumor size, and restore gonadal function. Similarly, the recommendation 2.2 is to offer medical treatment with cabergoline as first-line treatment to patients with prolactinoma and monitor for side effects of dopamine agonists that we have earlier mentioned in the last slide. When to consider surgery? So would prolactinomas require surgery? Yes, there could be situations like transfemoral surgery can be offered even to microprolactinomas if despite undergoing dopamine agonist treatment, the prolactin concentrations stay elevated. And the symptoms or signs related to the hyperprolactinemia continue to persist even after several months of dopamine agonist treatment, and the patient is intolerant to dopamine agonist and gonadal steroid replacement is not a viable option. For example, when pregnancy is desired. Okay. Then macroprolactinoma. In a macroprolactinoma, if there is compression of optic chiasm or visual deficits without rapid improvement with dopamine agonist. And so if you're having visual field defects and you are prescribing dopamine agonist, you'll like to have a response within few weeks. If that is not evident, you can consider offering surgery. And I'm sure our worthy panelists will comment further on this point as well. If the patient is resistant or intolerant to dopamine agonist, similarly, if the clinical, excuse, if the clinical manifestation of hyperprolactinemia persists despite several months of dopamine agonist treatment, and gonadal steroid replacement is not feasible, such as in cases where pregnancy is desired. In women with a giant lectotroph adenoma, which is more than 3 centimeters, who are planning to conceive, transfemoral surgery can be considered, even if the adenoma shows a response to dopamine agonist treatment. And that the rationale for this approach is actually that when the patient becomes pregnant and is having a macroadenoma, and discontinues dopamine agonist therapy, there's a risk that the adenoma may increase in size to a clinically significant extent. So all these cases are something which will be individually assessed and individually a decision will be made under a multidisciplinary team. Okay, radiation therapy. So there could be situations where you might consider radiation therapy even for a prolactinoma. So radiation is mainly reserved to thwart the regrowth of residual tumor in a patient with a huge macroprolactinoma after transfemoral debulking of the prolactinomas, which were resistant to cabergoline. And it should not be used for the primary treatment of prolactinomas. And the decision of transfemoral surgery or postoperative radiation therapy should be undertaken in a multidisciplinary team. So consider transfemoral surgery for prolactinomas when there is a resistance or intolerance to medical treatment, and consider postoperative radiation therapy in patients with drug-resistant macroprolactinoma after surgical debulking. So when your patient is on medical treatment, how to follow them up? Initially, check prolactin on monthly basis, just adjust the dopamine agonist doses to achieve normal prolactin and restore normal gonadal function. In patients with microprolactinoma who achieve normal prolactinemia, prolactin levels can now be monitored every 6 to 12 monthly. Serial visual field examinations in patients with macroadenomas with baseline visual field defects, and the decision again will be individualized. So serial monitoring of patients on dopamine agonists through prolactin levels. This is our recommendation 5.1 for the guideline. And 5.2 suggests perform serial assessment of visual fields through formal perimetry if there were evident initial visual field defects. Obtain serial pituitary MRI in patients with macroprolactinoma for periodic monitoring, and manage comorbidities in patients undergoing treatment for prolactinoma. So if the patient is having hypogonadism or bone loss, those comorbidities need to be addressed as well. How frequently should a pituitary MRI be done? In macroprolactinoma, repeat MRI in 1 year or even in 3 months. So that again will be depending upon the baseline status. If continuous increase in prolactin levels are there despite the patient receiving dopamine agonist, development of new symptoms such as galactoria, visual field defects, headaches, or other hormonal deficiencies, once maximum reduction in tumor size has been achieved, regular monitoring of prolactin level may be sufficient, and additional MRI scans may not be necessary. So coming to the last case, this is a 32-year-old gentleman treated with SSRIs for 1.5 years for his anxiety and depression, developed galactoria, right breast, serum prolactin was 683. His SSRI was discontinued by the treating physician. You can see that this kind of levels you won't expect with SSRIs. The patient later on, after few additional months, complained of decreased libido and visual complaints. Prolactin, which was repeated, was more than 1,000. Rest of the functions were normal. So what to do next? This was his pituitary MRI, and you can see that this is macroadenoma over there. And he had visual field defects as well. The recommendation 6.1 is to offer dopamine agonist and initial treatment to patients with macroprolactinoma and visual field defects. Can we consider withdrawing dopamine agonist in patients with prolactinomas? So there could be certain situations where you would consider this. Idiopathic hyperprolactinemia. So remember, so if there wasn't a pituitary mass at baseline, but prolactin was elevated, dopamine agonist was given, and the prolactin normalized, and 2 years have passed, you can stop dopamine agonist. Similarly, if there was a microprolactinoma or dopamine agonist treatment, prolactin level normalized, and 2 years have passed, dopamine agonist can be gradually tapered off. For macroprolactinoma, this is a tricky situation. Serum prolactin normalized on dopamine agonist treatment, 2 years have passed, and no visible tumor on MRI. And this is something which is very rare when we are managing macroprolactinoma. So in selected patients who have achieved normal prolactin concentration and more than 50% tumor size reduction, this could again be considered, but this will be a very tricky situation. Post-menopause, usually the risk of galactoria is very rare after menopause due to the low estrogen state in postmenopausal women, and thus tapering and discontinuation of dopamine can be attempted. Periodic follow-up after dopamine agonist withdrawal is again very important. The risk of recurrence of prolactinoma after dopamine agonist withdrawal ranges from something like 26 to 69%. And recurrences are mostly expected within the first year after dopamine agonist withdrawal. So prolactin level should be measured every 3 months for the first year. And if normal prolactinemia persists, then it can be checked on annual basis or earlier if symptoms recur. Pituitary MRI can only be offered if hyperprolactinemia recurs. So the recommendation 7.1 is to consider withdrawal of dopamine agonist in patients who have achieved long-term normalization of prolactin level and the tumor size has significantly reduced. And keep patients on periodic follow-up after withdrawal of dopamine agonist, as there can be a risk of recurrence. So this is the all the management algorithm that we have already discussed. I just skipped this in the interest of time. The guideline is available on JPMA website as well, and you can easily access and look at the these recommendations in detail and the algorithms as well. So as we discussed that with doses which are more than 2 milligram of cabergoline per week, valvular defects can occur. So echocardiography, baseline and serial echocardiography in patients requiring long-term cabergoline at doses that are more than 2 milligram per week is recommended. A situation could be a resistant prolactinoma, which should be managed in tertiary care setups under multidisciplinary team decision. Resistance applies to when the prolactin levels fail to normalize, and reduction in the size of macroprolactin by 50% is not achieved, and the failure rates are higher with bromocriptine compared to cabergoline. So those who are on cabergoline, there aren't any side effects. Then its dose can be increased to maximum doses, or switching to another to a cabergoline if the patient was taking any other dopamine agonist like bromocriptine. Transgender surgery can be planned when medical treatment is unsuccessful and there's an increase in the tumor size. If surgery is unsuccessful, then radiation can be considered, and temozolomide may be a therapeutic option in malignant and aggressive prolactinomas. So our recommendation 9.1 is to manage resistant prolactinomas in tertiary care centers with the expertise and availability of a multidisciplinary team. So in pregnancy, just remember that prolactin is a normal hormone in pregnancy as well. So there would be elevation of prolactin during pregnancy and lactation as well. So testing prolactin during pregnancy becomes unreliable. Remember, there could be a risk of tumor enlargement in pregnancy. Microprolactinomas around 3% can increase to symptomatic enlargement can be observed in 3% of the cases of microprolactinoma, while 15 to 30% with macroprolactinoma. And this increment is occurring because of the high estrogen state of pregnancy. Headache and visual loss actually become our focus of symptoms, which will then necessitate further management in such patients. So perimetry in each trimester, if there is a macroprolactinoma already diagnosed as a microprolactinoma, if there are visual field defects, then MRI pituitary can be considered, ideally without gadolinium after 16 weeks of gestation. So again, we'll just go through this algorithm for management of prolactinoma during pregnancy. If there's a microprolactinoma, it's recommended that at least the patient should be having 2 normal menstrual cycles, and then she should be allowed to withdraw her contraception and conceive, so that we are sure about her LMP. And then withdraw dopamine agonist when pregnancy is confirmed, because the risk of, as you have seen, the risk of tumor enlargement is minimal with microprolactinoma. But still, you will not just leave her like that. You will still consider a clinical assessment in each trimester with attention paid to headache and visual impairment. If there are any positive findings, so consider cell MRI without contrast. If there's evidence of tumor expansion, introduce dopamine agonist. If this is unsuccessful, consider neurosurgery or delivery if already more than 37 weeks of gestation. If there are negative findings, continue repeated assessment at each trimester. The situation would differ if there is a macroprolactinoma. The macroprolactinoma has significant propensity to enlarge during pregnancy. So again, these patients should be counseled to delay pregnancy till the tumor reduction is obvious, and especially the tumor is well away from optic chiasma when she conceives. If there is an intracellular or inferior expanding tumor, you can individualize case management by case basis. Options again will include stop the dopamine agonist, surgical intervention, preconception, consideration of dopamine agonist throughout pregnancy. A decision has to be made by an expert. Similarly, if the tumor is already previously expanded or invasive tumor, consider pituitary surgery preconception. Again, during pregnancy, clinical assessment with formal visual fields every 1 to 3 months. If negative findings, continue this monitoring every 1 to 3 months. If there are positive findings, SELA MRI without contrast. If there's evidence of tumor expansion, introduce dopamine agonist. If this is unsuccessful, consider neurosurgery or delivery if around 37 weeks of gestation, and then so that the potential of tumor enlargement due to pregnancy will no longer be there. Okay. So regarding the drugs, 2 drugs, bromocriptine and cabergoline, both have actually a wealth of data till date to support their use during pregnancy and have not shown any undesirable side effects during the intrauterine life or in the postnatal period. So can be safely used. Even with cabergoline, this is an older study, but till now they are an enormous number of pregnancies where cabergoline have been no problematic situation. So our recommendation 10.1 is to consider an individualized approach in managing women with prolactinoma and distributing pregnancy and during pregnancy. So with this, I think, yeah. So this is the end of the presentation. Thank you very much for your patient listening, and over to you, Era.
Thank you so much, Dr. Aisha. I think you have made it very simple, the clinical practice guidelines, and this easily applicable case-based approach is going to help we all us in our routine practice to deal with these cases of prolactinoma. Thank you so much. Now we are going to do the post-test first, and then till we will finalize the post-test and pre-test comparison, we will take opinion of our panel of experts. Okay. So, IT team, if you can, can we go through the post test? These are just 5 questions. We can do it. Okay. So, all the participants are requested to do the post test. I'm reading the first question. A 32-year-old female presents with secondary amenorrhea, galactorrhea, and decreased libido. Laboratory results show serum prolactin levels of 250. Okay, an MRI of the pituitary reveals an 1.5 centimeter lesion confined to the sella. What is the next best step in management? Okay, 10 more seconds. All participants are requested to take this post test also because it is going to tell you about how much you have learned from this session. I can see 50% have participated. I would request all participants to do this quiz. Okay, in interest of time, I think we should move to the next question. Okay, so next question is a 45-year-old male complains of progressive loss of libido and erectile dysfunction for 6 months. On examination, he has bilateral temporal visual field defects. Serum prolactin levels are 2500 nanogram per ml. And MRI reveals a 2.5 centimeter pituitary mass with compression of optic chiasm. What is the most appropriate initial treatment? I think that is well covered by our esteemed speaker. I would request all the participants to please do this quiz and do it fast so that we can move to the question answer session and our experts' advice. Okay, I think we should move to the next question. Okay, so the next question is a 28-year-old pregnant woman with a history of microprolactinoma presents at 16 weeks of gestation. She had been on cabergoline prior to pregnancy, which was discontinued over her pregnancy once her pregnancy was confirmed. She now complains of worsening headache and visual disturbances. Visual perimetry shows right superior chordinopia. MRI shows an increase in size of pituitary lesion to 14 millimeter with suprasellar extension. What is the most appropriate course of action? Restart cabergoline, check prolactin levels, transsphenoidal surgery. Okay, let's move to the next question. 54-year-old male with macroprolactinoma, 1.5 centimeter, has been on cabergoline therapy for 12 months. His prolactin levels have normalized and the tumor has significantly reduced in size on follow-up MRI. What is the next step in his management? Continue cabergoline therapy and monitor prolactin levels periodically. Discontinue cabergoline and repeat MRI in 6 months. Proceed with transsphenoidal surgery for residual tumor. Just 10 more seconds. Okay, now let's move to the next one, last one. Okay, so now the last question is 35-year-old female with a history of microprolactinoma, 6 millimeter in size, presents for follow-up. She has been on cabergoline for 2 years and her prolactin levels have normalized. What is the most appropriate next step? Continue cabergoline indefinitely, gradually taper and discontinue cabergoline, repeat pituitary MRI. Okay, so I think we are done with the post test. Until we compare the results and then we are going to discuss the answers, I would request Professor Najmul Islam for his opinion on today's session and his experience on the prolactinoma management, especially the difficult cases.
Assalamu alaikum, everybody. Thank you for inviting me for this as a panelist in this webinar. Dr. Aisha has nicely presented the guideline related to prolactinoma. I think it should be very clear to the participants of this webinar. The guideline is also available on the JPMA website, so they can access that and read that in detail, so they improve their understanding. Prolactinoma is a pituitary tumor, which is probably a domain of an endocrinologist rather than a neurosurgeon. So that should be so. It is primarily managed by the endocrinologist. So we should be very clear on this in our minds. And those those internists or other physicians who are not familiar to this should not be attempting to manage these cases and should refer the patients to the appropriate specialist really for further management. I think let's see what this pre and post poll questions answers really tell us, whether how much they have learned from this session. But I think if there are any questions which you want me to answer, I am ready to answer that. But otherwise, I think Aisha has done a good job.
Thank you, sir. I would request participants to ask questions on the chat box also so that we can cover those questions also. I would request Professor Emerita, Dr. Tasneem Hassan, Madam, your opinion on the session and the management of prolactinoma. Uh,
Okay, I'm unmuted now. Assalamu alaikum, everyone. Thank you for having me on this panel. Let me commend the Pakistan Endocrine Society for this wonderful effort to improve the management of prolactinomas by virtue of developing guideline, and congratulations to all the people who worked on this guideline and those who edited it. And thanks to Dr. Aisha for leading this effort as well as for presenting it so well and presented very well in terms of with reference to clinical situations, which more or less covered all the different areas of working with prolactinomas here. And it has been presented with great clarity. The guidelines are pretty clear. And as Dr. Najam said, they're available online. So those of you who are not comfortable handling it, you can refer to these guidelines and take guidance from there. And by all means, remember that this is a brain tumor or a pituitary tumor and falls within the realm of both neurosurgery, medicine, and gynecology and obstetrics. So multiple disciplines working and interacting here. And that it is important that not only do we disseminate this to the physicians, but we disseminate it to other specialties as well, the neurosurgeons as well as the gynecology and obstetrical specialists, because a lot of misguided investigations and MRIs are done for levels of prolactin that are related to other situations that Aisha has described. And often many of them are drug related, and many of these drugs can be discontinued, and the prolactin can be normalized, and unnecessary MRIs can be avoided. And similarly, unnecessary pituitary surgery can be avoided by making sure that people follow the guidelines and use medical treatment. This is, of all the pituitary tumors, secretory tumors, this is the one tumor that listens to oral medication, and cabergoline is very effective. And as Dr. Aisha presented, and the guideline says, even when there is some compromise of visual field or vision, as it were, instituting dopamine agonist therapy, usually with cabergoline, but even with bromocriptine, where cabergoline is not available, can improve vision within a matter of days. So that must be tried before you jump into surgery. So very well presented, and most clinical situations have been highlighted. Don't forget the drug-induced category. And I now encounter most commonly the levosulfuride-induced hyperprolactinemia, even more than the antipsychotic drugs, because
Thank
it
you,
is in
madam.
so much use. Thank you.
Iram, there are a few
Thank you so much,
questions
madam.
in
Uh,
the question and answer box.
we have few questions here. Yeah. Yeah, sure. I'm going to read those questions. So first question is for
Okay, I think Iram has talked off. So, Professor Najam, one question is regarding the. So, yeah, Iram, go ahead.
yeah, sorry. My internet connection is, I think, now troubling. Okay, so going back to the question. So for how much time prolactin be continued in patients with hyperprolactinemia without adenoma and with microadenoma?
I mean, I think the question is not very clear. Would you mind repeating it?
For how much time prolactin be continued in
Prolactin,
patients with maybe they are asking prolactin, or maybe they are asking about the
Dopamine
treatment
agonist.
in
Yeah.
patients with
dopamine.
hyperprolactinemia without adenoma and with microadenoma. Yeah.
Okay, yeah, I think this was dealt by Dr. Aisha. Clearly, that microprolactinomas may you need to continue it. And if you've used it for 2 years and the levels are normal now, then you can consider stopping it and then following the patient. I think this was dealt by Dr. Aisha. So I think I don't have to add anything here. It's already been answered.
Okay, the next question is, okay, so the participant have corrected this question in the next question. Okay, so how much treatment we have already covered it for hyperprolactinemia should be continued without adenoma and with adenoma. So they are specifically asking without adenoma also.
Without adenoma, तो वो तो idiopathic हो गया ना फिर. It should
जी,
be idiopathic hyperprolactinemia.
yeah.
Idiopathic hyperprolactinemia में तो there's nothing, there's no tumor visible there. So you need to continue, and once they've responded to it and then symptoms have resolved, you may discontinue, gradually tapering the dose and seeing the response.
Yeah.
देखिए
So
ये
that
idiopathic
is
hyperprolactinemia is a diagnosis which is only made when you have ruled out other causes.
yes, very well covered, and it depends on the symptoms of hyperprolactinemia. Okay, so next question is, do we need to check prolactin in all hypothyroid patients?
No, we don't have to check. ऐसा नहीं कि every hypothyroid patient should have the prolactin checked as well. Those who have symptoms related to hyperprolactinemia, then they may be checked. But as a routine, we don't check prolactin in each and every patient of hypothyroidism.
Okay, thank you, sir. If there are any other questions, kindly ask them in the either in the question box or you can ask on the chat box also. Now we are going to discuss the pre-test and post-test results. So this is question 1. Okay, so this is 32-year female. I just make it short that presented with secondary amenorrhea, galacturia, and decreased libido. And the prolactin levels were 250 nanogram and MRI showed 1.2 centimeter lesion confined to the sella. So what is next best step in management? Start dopamine agonist therapy, perform transsphenoidal surgery, monitor with repeat MRI. So initially 64% gave the correct answer, which is start dopamine agonist therapy, and then 91% have given the correct answer. So I think we have, delivered this to our participants. Next question. So question number 2 was 45-year-old male complains of progressive loss of libido and erectile dysfunction for 6 months. On examination, he has bilateral temporal visual field defects. Prolactin levels were 2500 and MRI reveals a 2.5 centimeter pituitary mass with a compression of optic chiasm. What is the most appropriate initial treatment? So initially 59% people said transsphenoidal surgery, and 24% said that dopamine agonist therapy, and 18% said stereotactic, which has now changed in the post-test response to 51% with the dopamine agonist therapy and 46% on the transsphenoidal. Dr. Aisha, would you like to comment on this question, on the answers?
Thank you, Iram. So the response rate actually, even the post session, is not very encouraging. So as we've discussed, and even right now in our worthy panelists have also mentioned this, even with optic chiasmal compression, if there's a prolactinoma, you start with dopamine agonist therapy as the first choice and observe the response rate. And as Madam has said, that even within days, you will witness an improvement in visual fields. So transsphenoidal surgery is not the first line option in such situations. Thank you.
Thank you, Dr. Aisha. Okay, going to the next question. So the next is 28-year-old pregnant woman with a history of microprolactinoma presents at 16 weeks of gestation. She had been on cabergoline prior to pregnancy, which was discontinued once her pregnancy was confirmed. She now complains of worsening headache and visual disturbances. Visual perimetry shows right superior coordinatopia. MRI shows an increase in the size of pituitary lesion to 14 millimeter with suprasellar extension. What is the most appropriate course of action? So restart cabergoline, check prolactin level, and transsphenoidal surgery. So the response was 21% with restart cabergoline, and that improved to the 50%. And then 48% said check prolactin levels, and which reduced to 28%, and TSS is more or less same. So I would just like to reemphasize that we don't check prolactin levels in pregnancy, and we monitor patients for the symptoms. And if patients develop symptoms and there is extension of lesion or increase in the size of lesion on MRI, we restart cabergoline. Okay. Next question. Okay, so question 4 is 52-year-old male with macroprolactinoma has been on cabergoline therapy for 12 months. His prolactin levels have normalized and the tumor has significantly reduced in size on follow-up MRI. What is the next step in his management? So initially 63% said continue cabergoline therapy and monitor prolactin levels periodically. And 26% said discontinue cabergoline and repeat MRI in 6 months. And 11% said that proceed with TSS for residual tumor, and which has improved to continue cabergoline therapy and monitor prolactin levels periodically. 73% then responded that. So bit improvement, and discontinue cabergoline and repeat MRI in 6 months by 22%. So basically we just need to emphasize on that in macroprolactinoma. So we continue with the cabergoline therapy and monitor prolactin levels periodically. So, we have to, we can't stop the drug when the prolactin levels are normalized right away. Okay, so we have to monitor this patient. And then we can see in macroprolactinoma, it is very rare that we can stop the drugs. So we just need to monitor. But in rare cases, we can even stop, but that depends on the individual patients. Okay. So next question. "35-year-old female with a history of microprolactinoma, there's a correction here, 6 millimeter presents for follow-up. She has been on cabergoline for 2 years and her prolactin levels have normalized. What is the most appropriate next step?" So 39% initially responded that gradually taper and discontinue cabergoline, which has improved to 71%, which is the correct answer. Okay, so we have already emphasized on that in microprolactinoma, we can stop treatment, but that would be done gradually and with a gradual tapering. But in the macroprolactinomas, we have to very careful before stopping treatment. We have to be sure that the tumor has gone and the prolactin levels are normal, and then we can decide on that. Dr. Aisha, if you would like to add something on these question responses.
Yes, thank you, Iram. I'm sure the response rates are better between the pre-session and post-session. There are a couple of questions in the question and answer box.
Again, yeah.
You can ask that.
Yeah, sure. Okay, so next question is, when we label resistant hyperprolactinoma, after how much period or dose of drug and treatment option? So they're asking when we label, yeah.
I think just let me answer let's ask Dr. Aisha this question. I have to answer a phone call, important call.
Okay, sure. Dr. Aisha, Dr. Aisha,
Okay.
just mute.
Should I answer this?
Yeah,
Yeah, sure,
madam.
madam. You can.
Okay, so the question is, when do you label it as resistant prolactinoma? Simply, every patient's tumor behaves slightly differently because this isn't a homogeneous disease. And at a point where the dose of bromocriptine has been maximized to the tolerable doses, and that maximum dose in resistant prolactinomas can be as high as 20 milligrams per week. You know, we've done 14, 15 milligrams in some cases, and you see that the tumor, the prolactin level is not settling. And sometimes, even if the prolactin level is settling or getting close to normal and near normal, but the tumor size is not settling. Usually, the prolactin level and the tumor size shrinkage parallel each other. And but when you see a disconnect between that two, and you've given maximally tolerable doses, usual dose of carbarocolene that is recommended is 2 milligrams per week. But if you exceed that 2 milligrams, in some guidelines, it's 3.5 milligrams also. But when you exceed 3.5 or 2 milligrams, which is the FDA mandated dose per week, then you could label it as resistant or difficult to treat prolactinoma, but much higher doses may work.
Okay, thank you, madam. Next question is, why should we discontinue cabergoline if they are safe in pregnancy? Madam or Dr. Aisha, Dr. Najam, if you want to answer.
Yes, I mean, it is safe, but despite that, it is to be extra safe. We are recommending to stop it and keep an eye on things, despite being the safety, and that's why restarting is also not of a concern if it is really required. Safety to hai, lekin to be extra safe, because you don't want to give any medications in pregnancy if you can avoid. So that on that principle, it is, despite being safe, it is recommended to stop it and keep an eye on the patient with the symptoms of the patient and the visual fields, and restart if required.
Thank you, Dr. Najam.
The safety is proven
We
beyond doubt.
Yeah, sure. So there is next question. The participant has says, very well done, team. I have a question. There is one 24 years unmarried patient, MRI showing 1:1 centimeter prolactinoma. She had it was done because she had amenorrheic cycles and galacturia. Scan showed PCOS, but prolactin levels were also done. They were in thousands. Patient is on cabergoline for a couple of years. Prolactin levels are normal. For how much time to I quote change cap? Continue. Probably they're writing continue cabergoline. Thank you.
Do you want me to answer?
Yes, sir. You can answer or.
I mean, देखिए ये जो इन्होंने 1 by 1 centimeter है, this is at the borderline of a micro and macro. Some people call it a mesoadenoma as well. Anyway, ये कह रहे हैं कि prolactin normal है, लेकिन उन्होंने कोई बात नहीं की about the tumor size.
हाँ, tumor size का कोई जिक्र
So
नहीं
we
है.
need to know that information as well before we decide कि भाई इसको continue करना है या discontinue करने का कोई plan हो सकता है.
Madam, if you want to add anything.
Not really. Like Dr. Najam said, this is in between kind of a macro and a micro. And if 2 years therapy has already been given, if prolactin is normal and if periods are regular, you just document that the tumor has disappeared or is not visible anymore, and then cautiously taper and withdraw, because it is, like we said, on the boundary. It may behave like a micro, but it may behave like a macro, in which case you may need longer duration of treatment. So we need to see what the tumor is doing.
Okay, thank you so much. I think we can conclude this session. I mean, it was very knowledgeable session. Thank you so much, Dr. Aisha, for covering key aspects of diagnosis and management of prolactinoma with an easily applicable case-based approach. I'm sure that we can integrate these guidelines in our clinical practice, in our routine clinical practice. Thank you so much for that. Thank you, Professor Najmul Islam and Professor Emerita Dr. Tasneem Hassan, for your valuable insights and knowledge. Your knowledge has been invaluable in deepening our understanding in the field of endocrinology. Always, it's honor to learn from both of you. Thank you so much for being here. And I would like to thank Pakistan Endocrine Society for arranging these sessions. I'm sure that many people have learned a lot from it. And thank you for the participants for taking out time on this Saturday afternoon. Thank you once again. Have a great day.
Thank you very much.
Thank you.
Thank you very much. Allah Hafiz.
Allah Hafiz.